Thank you, and thank you all for coming. Epilepsy is one of the most misunderstood of diseases. Even the word seizure comes from being seized by supernatural forces, the gods or the devils, depending upon which century you're in. And if epilepsy is misunderstood, then the condition psychogenic non-epileptic seizures is even more misunderstood. In fact, very few of my patients have ever heard of it, and probably most primary care doctors have not heard of it as well. And yet, it's pretty common, at least in referral centers. It's very common, and it is often misdiagnosed, and it is often mistreated. So it's great to be invited to have an opportunity to talk about this misunderstood condition and see if we can shed some light and answer some questions. We have with us a moderator, Dr. Ariella Karasoff, and I will turn over to you for questions. And please feel free to direct questions to any of us, and we will feel free to answer any of the questions as best we can.
Well, thank you all of you for joining us this evening, and thanks to the audience for being here. We'll start with you, Dr. Fisher. Before talking about psychogenic non-epileptic seizures, or PNES, and how they differ from epileptic seizures, could you say a word about what are epileptic seizures?
Sure. An epileptic seizure is an electrical storm in the brain. Normally, the brain cells function fairly independently with a lot of chatter. If they fire too synchronously, too much together, in too high a surge of voltage, then a seizure results. And the type of seizure depends upon where in the brain that abnormal electricity comes from. If it comes from the motor control area, you may have twitching of your hand. If it comes from the visual area, you may see lights or visual hallucinations. If it comes from the temporal lobes on the side of the brain, the most seizure-prone part, then there may be fumbling, confusion, loss of memory, robot-like behaviors called automatisms. And if they spread to the entire brain, then you have what is often called the grand mal, or more officially the Tonic-Clonic seizure, with stiffening and shaking. Now, a psychogenic seizure is different in that it does not have the electrical storm associated with it. But physically, it can look rather similar to an epileptic seizure and can take some work to diagnose which is which. Let me show you one of each, and you can see that there's some similarity to them. I've got permission to show these seizures, but I've rather anonymized them anyway, cutting off the head. Well, I didn't really cut off the head, just photographically. So you can see this is an epileptic seizure, and it's in the tonic stiffening stage. At this point, the person would be unconscious. And even though they might be making a cry if we had the audio with it, it's because of the expelled air against the closed throat. We think it's not because of pain. And now it is in the clonic jerking phase. These seizures go on for typically a minute or 2 minutes, and then the person slowly wakes up, usually not remembering any of it. This is a non-epileptic seizure. And experts might be able to tell them apart due to the asynchronous movement of the limbs or the type of movements, but it can be pretty hard. You can see that there's a fair amount of shaking and movements that occurs with either of these. Now, in the case of the non-epileptic seizure, the brainwave activity, and this is 10 seconds of brainwaves from different part of the head called an EEG. The brainwave activity is nice and low voltage and regular, and there's even something called what looks like a sine wave for you engineers, a 10 per second alpha rhythm, which is the brain's healthy idling rhythm in the brain, which you would never see during a generalized tonic-clonic seizure. And here is a tonic-clonic seizure, and the amplification here is turned down so that really this is twice as big as it looks compared to this. But you can see the high voltage, rhythmical, and synchronization across the head activities. So we can tell an epileptic from a non-epileptic seizure from the EEG if we happen to record it, say in an epilepsy monitoring unit, during the event. In other cases, we have to use other clinical factors for the two of them. Does that answer your question, Dr. Karasoff?
That does. Thank you very much. And Dr. Fisher, are there some conditions that imitate epileptic seizures but are not epileptic seizures?
That too is a very good question, and there are many of them. One of the most common would be a fainting type event, which is called syncope in medical terminology. There also can be sleep disorders, people who fall asleep inappropriately. Perhaps they have narcolepsy, perhaps they're neurosurgery or psychiatry interns and they're up all night. And these get confused with seizures. People who have severe migraines can sometimes become confused, even without a very large headache, and those are particularly hard to diagnose if there's fluctuation from migraines. Hypoglycemia and other metabolic conditions can cause seizures, and there's a whole checklist of imitators of seizures on a medical basis. Then aside from the medical imitators of epilepsy, there are the psychiatric imitators of epilepsy, which you'll be hearing much more about from my colleagues later in the talk.
Perhaps we can turn the microphone over to Dr. Kanner. And Dr. Kanner, what are the psychological imitators of seizures?
So among the more frequent type of imitators are panic attacks. Very often in the course of a panic attack, an individual may perceive that they may become somewhat confused in their thinking as they hyperventilate very strongly. And these can be interpreted by the emergency room physician as, oh, you probably had loss of awareness of your surrounding, you probably had a focal seizure. Nightmares, night terrors often can be associated with diagnosis or misdiagnosis of epilepsy. Then you have not infrequently individuals who have a condition known as intermittent explosive disorder. This is a condition where individuals start becoming increasingly agitated, and it can increase in intensity to the point where they become violent. And at the end, they have no recollection of what transpired. And that lack of recollection gets often interpreted as a possible seizure. And we often will see these patients in the epilepsy clinics for evaluation for seizure disorders. Interestingly enough, individuals with intermittent explosive disorders will improve with anti-epileptic medication. So of the type of the anti-epileptic drugs that have mood stabilizing properties such as carbamazepine. And so that further enhances the confusion. And then you have individuals with autistic spectrum disorder that have a lot of mannerisms, and as part of their mannerism and behavioral patterns, they may often be confused as epileptic seizures. And as Dr. Fisher mentioned, the best way in kiddies with autistic spectrum disorder of distinguishing whether these are seizures or not is by doing a VDG monitoring study.
Thank you very much. I'll turn the next question to Dr. Berry. And Dr. Berry, why do people have PNES?
That's another good question. The answer, however, I think is hard for us really to know. We understand a lot of the phenomenology of these particular events. The etiology of the events, however, is really unclear to us. We have ideas, and the ideas basically come from the ways in which these episodes actually present and the context in which they present. So if you ask why, it may be a manifestation of severe depression. We consider this really a communications dysfunction. And we can go in and talk a little bit more about this, but the way we consider this is many of these people have severe anxiety disorders, as Andy was just talking about. They also have episodes of PTSD, post-traumatic stress disorder. Many of these folks have been injured as a child in a variety of different unfortunate ways, which has resulted in them developing a communication deficit. In 1975, Peter Sifnios, actually from Massachusetts, talked about a disorder called Alexithymia, and the Greek basically means something for which they have no words. And many of these people suffer from alexithymia. You have to remember that when you were all kids and your parents, when you were growing up and you had something happen to you, your parents labeled that for you. In situations, however, where the parental situation is non-functional, people develop a way of communicating, and the way they communicate is somatically by physical manifestations, rather than being able to label emotional situations. So that's a long answer to your question. We also are starting to look actually at some of the neurologic anatomic underpinnings. The diagnosis actually of PNES really has changed in some ways, at least the nomenclature in the DSM-5. Now these are called functional neurologic disorder. And I actually really like that terminology because that's kind of what it is. It's a functional disorder. And I like it when I present the diagnosis to patients too, because many times these folks have been picked up by EMT or doctors in the emergency room, and you would never expect anybody to say anything to them like you're faking it or this is not real or whatever, that anybody would actually say that to an individual. But they do, and what we're understanding now is that this is a functional, anatomic, physiologic process. So we have a lot to understand more about this particular disorder, but that's kind of a long answer to your question.
I see that Dr. Fisher has something to add.
John, we often treat the same patients together, me from the neurological and you from the psychiatric standpoint. A lot of the ones I've seen have either suffered some form of abuse when they were younger, or they're in some situation in which they can't cope. And, we use words here like functional and conversion disorder. Could you say a little bit about what those words mean in that sort of situation?
Absolutely. It's funny you asked that question. Conversion disorders actually is a terminology that is really ancient in the fact that it goes back to the 1800s. And it was a terminology that was coined by Freud, and he basically was talking about a conversion of an emotional conflict into a physical, somatic presentation, which resolves that particular conflict. I oftentimes use the analogy of a boy getting angry at his father, ready to hit him, and realizes that he can't do that, and developing a paralysis of that particular arm. So he's converting basically the conflict into a physical manifestation, and thus the terminology conversion disorder. It's most of the time it's really hard. There may be aspects of that in most situations. I don't think that's necessarily true, but it's a terminology that's been used in the past, and I like functional better. I think that is more apropos to many of the cases that we generally see.
I just wanted to add one other perspective. And first of all, the psychogenic non-epileptic seizure is a very pleomorphic condition, so there are many causes. And there are a certain percentage of patients who, when you do an evaluation, you don't identify at the time of the evaluation any current psychopathology. And very often, just by telling the patient, you don't have epilepsy, these are not epileptic seizures, you don't need to be on medication, patient goes home and the events stop. And so these are individuals in whom probably whatever triggered the events is not operant anymore, and what maintained the persistence of these episodes was the fear of having epilepsy. And then you tell them, no, you don't have epilepsy, and it's gone. So I think we have to also keep that concept in mind, because very often patients will tell you, but doc, I'm not depressed, I'm not anxious, my life is going well. And we have to take him at their face value. It's not that they're trying to deny psychopathology. Very often, that can be also going on. And whatever triggered it was not operant anymore at the time of the evaluation.
And if it's accumulated stress, it may not be stress of the moment
Right.
of the attack.
Right.
Yeah, so that leads nicely into my next question, which is for Dr. Barry. Is it current or past stress? And if it is past stress, why would there be a delay?
It's actually both. So the way I look at it is again as a communication dysfunction. I think that the thing that Andy just mentioned, I think also bears a little bit of expansion, and that is when a patient goes to a unit like Andy's or ours here at Stanford, they're seeing a neurologist. The neurologist understands, sits down, talks to them. They get their communication message across. They're listened to. Their appointments are made for them for the future, so they're not abandoned. They'll be continuously followed. So when these miraculously go away, they don't miraculously go away. They go away because, in many ways, the function of these particular events actually has been fulfilled. So as far as past stress or conflicts are concerned, the past stress, especially as a child, can cause permanent neurologic damage. And so it's important to remember that. We're learning much more about those that particular aspect of all this. I mean, affects brain function, again, on a permanent basis. These are people who have had deficits that, because of their particular backgrounds, will be with them forever. It doesn't mean that it's insurmountable, or that you can't treat it, or they can't learn alternate ways of developing and dealing with issues and problems, but that Achilles' heel will remain in some particular capacity. Why does it happen now? There's usually a precipitating event, and it can be a variety of different events. It may remind them of a previous trauma. It may be, as Bob actually was talking about, something that just overruns any kind of coping strategies that they have. And it may, because of that, manifest in this particular fashion. The next questions you're going to ask, I'm going to usurp your role here for a second, and that is, I think these are incredibly fascinating. I mean, when you look at what Bob just showed you, and that this is a psychologic phenomena that actually took place, I think that's really a fascinating phenomena. But the issue is that somatoform disorders is what these used to be called. And somatoform disorders are very common, and it's not only in neurology. We can go through every branch of medicine, actually, and each branch has their aspect of psychological, physical manifestations. You can do, certainly with GI, you talk about ulcers, irritable bowel syndrome, cardiovascular disease, dentistry, and TMJ. So we can go through, this is not an uncommon phenomena. It may manifest differently in different patient populations. And the next question is, why does that happen? And I don't know. I wish I did. But I think it's fascinating, but it's really very, very common. And again, that difficulty really expressing your emotions, talking, communicating, and having it be a somatic communication is the way this actually happens frequently. Oftentimes people will say, I don't know why it happens at night, because I'm totally relaxed and rested at night. Why should that actually take place? And the way I generally understand that is you all remember when you were back in biology 304 and you had your big exam, whatever, and you got through that exam, and afterwards you thought you would be feeling fantastic, and you're not. It's after the emergency. You get yourself through at all costs, but it's after the emergency is when things fall apart.
There's one observation I wanted to add to what John said, and that is that in addition to the events that you see happening to the patient, headaches are very frequent. And I don't know if you've had that experience, but in my experience, a vast majority of patients with psychogenic non-epileptic seizures report constant headaches. And sometimes to the point where we have to refer them to our headache specialist because they don't respond to pharmacotherapy. And so this is just to illustrate the complexity of the problem.
And let me expand on that. It's not just headaches, it's also pain in general. So pain disorders are extremely frequent in this population. Just remember also that people with depression, and many of these people have episodes of major depression in the past or have a depression at the present time. Somatic complaints and pain disorders. I'm sorry?
Mike, farther away.
Further away? Is this good?
Halfway.
Halfway? Like that? Okay. So pain is very, very frequent in this patient population too. So it's not just headaches, and I think Andy's absolutely right. That's what we it's frequently seen, but pain complaints of a variety of different disorders are also very frequent. Things like fibromyalgia, chronic fatigue syndrome, those sort of things I think are also very common in this patient population.
I think all of your comments nicely highlight the ways in which the mind and the body are intertwined in these disorders and in somatoform disorders in general. So thank you for that. Maybe we can turn the microphone over to Dr. Canner then. Are these episodes in a person's control?
So again, as I alluded before, psychogenic non-epileptic seizures is a very pleomorphic condition. And you do have a small percentage of patients, and in my opinion, it's a small percentage of patients who have what we call malingering, and which is a form of volitional, movements or events that are under their control. But in my experience, it's actually a very small percentage of patients, and these are people in whom there is a gain to be made from having these episodes. I remember, patients who are suing, somebody because of injury, and they develop these kind of things. This is the kind of things. But I think the majority of patients don't have a conscious control, and I think this is a very important concept that needs to be transmitted to the patient and the family members, because it is one of the big fears that patients experience, that it's going to be thought that they've been making it up, that they've been faking it, that they're doing it to attract attention. And it's one of the causes that patients may react, why are you saying that? I've been told I have epilepsy all these years, and I make it a point to clarify not only to the patient but to the families that this is not something that is being done volitionally. What are the mechanisms that are operant in causing these episodes? I think it varies from one patient to another, and patients over time, through a variety of interventions, and now cognitive behavioral therapy has been found to be an effective treatment of helping patients to have less of these episodes, or even stop having these episodes, can in a way give the impression that patients are under control. John used to, and you still do, hypnosis in order to identify triggers of these events. But in the majority, this is not something that patients can stop like that.
I just want to second that. I used to run a group here with patients with non-epileptic seizures, and Ariella's running one right now. And one of the messages at the end of the group, everybody had all their events actually by the end of the group, which actually was 8 or 9 months long. By the end of the group, everybody had their seizures under control. They didn't have any more of their non-epileptic events. And they said, when you go out and talk to people, I asked them at the end, what do you want me to do with this information? Well, publish it, but go talk to people and tell them these are not pseudo. It used to be called pseudo seizures. Please tell them that these are not pseudo, that has a very pejorative quality to it, that we didn't have control of these events. We've identified triggers and reasons why these things happen, and we've been able to control it, we've learned about it, but we had no control of it. Please go tell people that these were not pseudo seizures, that these are real events that happened to me and I had no control over it.
I think that's a very important message, and one that's important for patients and their families to share and to educate more of the population about this disorder. Dr. Fisher, I have a question for you. How do you make a diagnosis of non-epileptic seizures?
We have marvelous technology now in the neuroscience field, but the diagnosis of seizures and epilepsy, which is the condition of spontaneously recurring seizures, is still mostly made by the history. That's the first point. We take the description of the events and we use our experience to tell us, is it an alteration of sensation, motor function, behavior, awareness, punched out in time, somewhat stereotyped if it repeats? That sounds like an epileptic seizure. Or does it sound like somebody fainting when they stood up too suddenly, or somebody falling asleep who can be aroused? So we take the history. If Johnny has a, quote, seizure every time Jimmy takes his toy, it's probably not an epileptic seizure, because that's not historically consistent. It's some type of behavioral episode that's occurring. So the most important thing is to start with the description of the event. And we also look for psychiatric factors. It used to be said when I was in training that a psychiatric diagnosis is a diagnosis of exclusion. You have to rule out everything else first. Well, that's not true anymore. There are criteria, there are things to look for in a person's background that are risk factors for psychogenic non-epileptic seizures. We heard some of them. The only thing is you can't assume just because they're there that that's what the answer is. You have to look farther and you have to confirm it. We take a history, we do an exam to see if there are any signs of neurological damage that would go along with epileptic seizures. We run an EEG. An EEG is an electroencephalogram. It's brain waves. It shows the up and down voltages across a person's head because the brain is an electrochemical organism, rather like a car battery for a Tesla, although a bit more complicated than that. So with epileptic discharges, we have that high voltage storm, but half of the people with epilepsy will have what we call spikes, abnormal surges of electrical activity between seizures. So if somebody has a somewhat convincing story and has those spikes, then I'm fairly convinced that's likely to be seizures. These EEGs are normally 30-minute, 1-hour affairs in the outpatient clinic, so we don't usually capture the seizure event itself. We're looking for these epileptic spikes between seizures. However, if it's important to capture an event, then we can do some type of more prolonged monitoring. We can send people home with an EEG headset for 24, 48 hours that will record it on a cartridge and look at it all later when they bring it back in. They can push a button if they had what they thought was a seizure, and we can see what are the brain waves doing at that time. And then the gold standard test is the inpatient video EEG monitoring in what's often called an EMU, not only an Australian bird, but also standing for Epilepsy Monitoring Unit. And in that circumstance, we may withdraw medication, something that would not be safe on the outside, but under direct supervision, it can be made safe, to provoke the events, record the video, audio, brainwave picture, and make a determination if those are epileptic seizures. In some cases, despite our best efforts, we still can't tell, and then we may do what's called a therapeutic trial. We just may try some anti-seizure medicines if we think that's the avenue to try, or we might try antidepressant medications if we think that's the avenue, or we might use medications that might address both and see what happens. So it's a process.
One of the advantages of practicing medicine in the 21st century and having smartphones is that today we can ask family members to take your smartphone and videotape the event, because that often can help us capture the actual event. And while most of the time, if it is a convulsive event, you could reach a conclusion of, yes, this doesn't look like an epileptic seizure. You have to also keep in mind that certain events can have clinical characteristics suggestive of psychogenic non-epileptic events and maybe clinical seizures. And the other non-convulsive events where the individual just sits there, stares, and is unresponsive, those are more difficult to distinguish. But use the smartphone today to capture the events. You bring it to the consultation to a physician, you'll save a lot of money.
To make this just a little bit more complicated, people with epileptic events can also have non-epileptic seizures as well. So maybe 10 to 15 plus percentage of patients with epilepsy can also have non-epileptic events. So this becomes much more complicated. It's not an either-or proposition either. So you have to pay attention to that. People with TBIs, for example, have seizures, as Bob originally talked about, as far as kind of overwhelming your ability to cope. Certainly a lot of CNS disorders can certainly overrun somebody's ability to cope and result in a non-epileptic seizures, but they also may have epilepsy too. So it makes it much more complicated.
I just wanted to illustrate a point that has not been emphasized, and that is that people can walk around with a diagnosis of non-epileptic seizures for years. And 1 out of every 3 to 4 patients that come to our epilepsy monitoring unit, and not only ours in Miami, but throughout the country and throughout the world, don't have epilepsy. And many of them have been treated as if they suffered from epilepsy for years and years. And so that's something that one has to always keep in mind when evaluating patients with events.
I've had several patients referred to me for brain surgery to cure their epilepsy who had psychogenic non-epileptic seizures. We didn't do the brain surgery.
Dr. Fisher, maybe you could say a little bit more about those patients who have, as Dr. Berry brought up, both epileptic and non-epileptic seizures, which certainly sounds like a complex patient group.
Yeah, that would be our most complicated or complex patient group, people who have both. Even that group is somewhat diverse because you may have someone who had epileptic seizures as a child. And then they may have gone away, and now other events are occurring, so we assume that they must just be the adult manifestations of those childhood epileptic seizures. But in fact, these new events are really something different, and they're psychogenic non-epileptic seizures. So that is one scenario, and that's been fairly common in my experience, almost as though the brain has somehow learned how to have epileptic seizures and is in that kind of groove, so that when other symptoms happen that convert from the emotional to the physical, it takes that pathway. I speculate a bit on that. The hardest patients of all are those who are having epileptic seizures on Monday and non-epileptic seizures on Tuesday. The best way to get a hold of those is to do the video EEG monitoring and explore with the patient and the family, what does this one look like to you? How many of these do you have at home? What brings these on? How about those? What brings those on? And in that circumstance where they have both condition mixed, we clearly need to use a dual approach, both anti-seizure medications and psychiatric treatments that we haven't talked about yet, but we will, and take a very comprehensive approach to the patient. But they can be very difficult to treat.
I think one group where you may see a higher prevalence of both epileptic seizures and non-epileptic events are individuals with cognitive developmental delay. And these are individuals who start with epileptic seizures. And eventually they learn, when I have my seizures, I don't have to go to workshop, or I don't have to do this or that. And so it becomes like a Pavlovian response. And again, it's not that they're doing it, they're faking it. It's just a learned behavior. And they're not doing it to attract attention. In my experience, it's more as an avoidance type of behavior. And some studies have suggested that among people with non-epileptic seizures that are cognitively impaired, 40% will also have epilepsy. So the comorbidity is higher.
It's actually a good example. We'll talk about treatments in just a little bit, but whenever I see any adult or child that comes in with a developmental delay that we're concerned about the possibility of these being non-epileptic events, what I usually realize is you have to sit down, you have to find out about the system and what's going on in the system. You have to do that generally, but in this particular patient population in particular, because what's happening is sometimes it's a stress response, that there's something going on in the group home that's problematic, or an individual in the group home they're having a lot of difficulty with, or a romantic breakup or whatever, and it'll be manifest not in words, because words can't be used in this particular situation. It'll be manifest in behaviors. And so it's actually a good example of what happens in people who do have cognitive abilities of a normal range and also have verbal abilities but haven't been able to use them for one particular reason or another. It's a similar kind of situation.
Along those lines, and thinking about stress, Dr. Fisher, can stress provoke epileptic seizures or just PNES?
Clearly both. Surveys of people who have ordinary epilepsy, not psychogenic non-epileptic seizures, typically when asked, will list stress as the number one provoking factor for their seizures. There are many other provoking factors: missing sleep, missing medicines, physical illnesses. Some people may be provoked by sugars or dietary indiscretions and alcohol and so on, but stress is often listed as number one. But it isn't a one-to-one relationship. It's not every moment they get stressed they have an epileptic seizure. If that appears to be the pattern, then I'm thinking it's probably not epileptic. And of course, we've already talked about the role of stress in PNES, psychogenic non-epileptic seizures. It's very major, but it's often remote stress. Sometimes, perhaps, is it fair to say, with a recent reminder at some level, maybe not an obvious, but a subtle reminder of that past stress. So stress is a common face to both of those conditions.
And Dr. Kanner, we know that stress accompanies a variety of psychiatric conditions. Do other psychiatric conditions tend to accompany PNES or psychogenic non-epileptic seizures? And if so, what should be done for those comorbid psychiatric conditions?
Yeah, so John already alluded to that. As I said, psychogenic non-epileptic events is a very pleomorphic condition, and in many of these patients, you will identify depression and a long history of depression as among the most frequent comorbid conditions. Very often it's not only depression, it's depression and anxiety disorders, and you're going to need to treat those underlying conditions. So those are the most frequent conditions. Post-traumatic stress disorder is a big comorbid condition, and you can have associated with that panic disorders. That often, the panic attacks often gets misdiagnosed as epileptic seizure. So you have all of that spectrum of the mood and anxiety disorders. Personality disorders are not unusual in people with a long history of psychogenic non-epileptic seizures. And this is also seen in people who've been victims of very traumatic lives throughout, being victims of severe abuse and neglect. Very often you identify attention deficit disorder coupled with mood disorders, and the combination of attention deficit disorder and a mood disorder lead to these personality disorders when these people grow up, and if they've been victims of adverse situations in their life, particularly abuse, it's the perfect storm. And this makes the treatment of these patients quite challenging for a psychiatrist, neuropsychologist, psychologists. And so you have to do a very, very careful and detailed psychiatric history in order to identify the psychiatric comorbidities associated, because essentially psychogenic non-epileptic seizure is a neuropsychiatric disorder. And as John was saying, is a condition where we are starting to identify neurological subtle neurological changes in the brain and neurochemical changes in the brain with very strong psychiatric manifestations. But the treatment is a psychiatric treatment, and that's your target, you see, and you really have to do very careful history.
Thank you. And Dr. Kanner,
Yeah.
how do you tell someone that they don't have epilepsy but have PNES?
So that is a excellent question, and this is one of what I like to call the art of medicine when we present the diagnosis. You have to be extremely careful how you present the diagnosis, because it's not as easy as to saying, great news, you don't have epilepsy, you don't have to take all this medication, bye, have a good life. It's not as simple as that, because what you're doing in many of these individuals is you're basically changing their entire perception of their life. You're taking away their identity as somebody who has lived around their seizures, and all of a sudden you tell them, no, you don't have seizures, you don't have epilepsy. The other
Replace that with.
Yeah. So this is what I'll tell you what I do. First of all, I've learned through the years that telling the patient you have a psychogenic disorder, psychogenic seizure, very often is encountered with a barrier. What do you mean psychogenic? What do you mean? Are you saying I'm crazy? Or are you saying that I'm faking it? And so the first thing I say is, you don't have epilepsy. Well, what is it, doc? Well, these are events that mimic epileptic seizures, and this is the reason that it mimics epileptic seizures. I show them the EEG recording of a person with epilepsy. I show them their EEG and say, you see, there aren't these patterns. Well, what is it, doc? Well, these are things that happen in people who've had a history of anxiety, depression. We see it in individuals who've been victims of traumatic experiences. We're seeing it now in soldiers that are coming back from the war theaters, and it's a way of their brain to protect them from traumatic experiences. Does that sound like this may be applying to you? And I let them see if they can identify with this, because that may be the most, because if they're telling me, oh no, that doesn't apply to me, what that tells me is, doc, I'm not ready to hear that this is psychogenic. And I can banging in the head all I want with telling them this is psychological, and they'll just build a thicker barrier. So my approach is, in those individuals, is to say, okay, well, I don't know what it is, what's causing it. We can do a neurologic, neuropsychological, and neuropsychiatric evaluation to identify. And then if they say, oh, no, I don't need that, that tells me even further. I'm not ready to hear what you're trying to tell me. So what I do with those patients is I say, okay, the most serious complication is of you having these events, ending up in an emergency room. The doc in the emergency room is not going to know that these are not epileptic seizures. And because these events often mimic recurrent seizures, what we call status epilepticus, you can end up in an intensive care unit, intubated, and doctors, giving you a lot of medication. So you need to avoid going to the emergency room I also explained these events are not causing you brain damage. The electrical activity of your brain is not affected. So this is in one group of patients. My experience has been, however, that people who've been victims of abuse or traumatic experiences are readily able to say, yeah, I was a victim of rape when I was a child, or when I was an adolescent, or this happened to me. So a majority of patients, if you present it in that way, will be able to tell you. And then you ask them, well, do you remember what it was like when you were being raped by so-and-so? And very often patients will tell you, I don't remember. My body was there, but I wasn't there. And that allows you to connect, to make the connection. So just like your body is, protecting you, your mind is protecting you from experiencing the traumatic experiencing of the rape, eventually this is a mechanism of defense that your mind uses to protect you from facing certain situations that are uncomfortable. So it's a
Finish your thought.
yeah. You normalize it for them so that it becomes an acceptable option. You see, but I think that the big error that we make is going to a patient and say, "Oh, you have psychogenic events. Go to see a psychiatrist. Goodbye," because there we're building up the barriers, and that results in more difficult referral to the treatment.
I want to emphasize that for any people who are listening. I've been doing this for 30 years, and it's gotten better. But many neurologists just have a terrible approach to psychogenic non-epileptic seizures. You're hearing from Dr. Kanner and Dr. Berry how it should be approached. But the usual approach that we see is what we call diagnose and adios. The neurologist all of a sudden says, "This is psychiatric. It's not my business. Goodbye." It's just another form of abandonment in their life. Whereas this is a neuropsychiatric condition, and it needs a joint effort between neurologists and psychiatrists over the long term to take care of it.
See how we often fail our patients who are really suffering. I also wonder, are there patients for whom there is no identifiable stressor or trauma, but who have PNES?
I'll defer to Dr. Kanner on that.
Oh yes, and as I was saying before, we actually did a study a few years ago where we actually tried to identify where the predictors of the course of PNES after the diagnosis. And we found that about 20% of the patients, we couldn't identify at the time of the evaluation any psychiatric condition. Those patients did well. When they were discharged, they stopped having the events. We actually follow the patients after. I am a strong believer that you have to follow the patients for various reasons. First, because you don't abandon the patient. Number two, because you don't know that these patients may not have epileptic seizures as well, and when you're taking them off medication, boom, the seizures may come. Number three, because very often they have other comorbid conditions, mainly pain and headaches, for which the psychiatrist may not feel as comfortable in handling. So those are the kind of patients in whom you don't identify the conditions where they stop having the event and whatever was that caused the events in the beginning is not operant anymore, and that's it. For example, one of the conditions that Dr. Fisher was alluding to, the convulsive syncope, gets often misdiagnosed as epilepsy. You tell somebody you have epilepsy, you're messing up with their lives big time. They can't drive, they can't do a lot of these things. And so that in and of itself can become a self-fulfilling prophecy until you do the evaluation, and then that's the end of the...
So we should probably be a little briefer with our answers so we leave time for questions in the remainder.
So a couple of, just 3 more remaining questions. We've talked a lot about diagnosis and giving the diagnosis, and touched a little bit on the role of psychotherapy in treatment, but perhaps Dr. Berry, you could say some more about the general treatment approach for PNES.
Sure, we just actually finished a study. It was a 3-institute study at Brown and University of Cincinnati looking at different approaches. Since the etiology of many of these events are depression, we looked at the treatment of depression alone with medication. We also looked at a group of patients with CBT, which is cognitive behavioral therapy, and a group that was treated with both, and then a treatment as usual group, as Bob alluded to before. And actually the combined approach, which is always the case with CBT and medication, did best. But there is a group of patients who are treated with medication, and once the depression gets better, many of these non-epileptic events also get better. So cognitive behavioral therapy is very useful. I use a psychodynamic approach because, again, as I've talked about these, I think this is a communication issue. And just as Andy was talking about, with people who don't have a specific targeted stressor or whatever that caused these, again, they're trying to communicate in a somatic fashion. And if this can be understood, these patients actually do very well. The patients who do very well are those that have had the disorder for the least amount of time. So in other words, patients who have had them for less than a year or 6 months, there's a high percentage of those patients who actually will do well. And that's one of the reasons, and Bob alluded to this in the very beginning, is that you try and get these patients in as soon as possible before this gets to be a part of their personality, the way that they approach the world, because then it becomes more and more difficult to rectify it. So the shorter duration of time that this has actually been a problem, those patients actually do quite well. And letting the patient know that, I think, is actually very critical too, that this is a treatable disorder.
And Dr. Fisher, as a neurologist who follows people with PNES in clinic, what is your experience with prognosis?
I think most of them end up doing well. When I was starting in this business, it was said that the prognosis was something between poor and dismal, but that's because their doctors weren't doing anything for them. They were just ignoring or abandoning them. So now if you take a joint comprehensive approach and you try to address the underlying causes for the PNES, and you treat it. You treat a depression if it's there. You do cognitive behavioral therapy if it applies. Then the prognosis can be pretty good. My experience is that people vote with their feet. If they show up for treatment, they get better. If they don't show up, for some reason they don't want to be treated, and they will typically go on having the events.
Can I just say a statement? I think one of the things that you when you look at the three of us up here, we're up here for a reason. I'm a psychiatrist, and Andy is certified in both psychiatry and neurology, and Bob, obviously, a neurologist. This is a very changing time, and that is psychiatrists, neurologists. The way I look at it, I'm very at home working with Bob over in the unit, more in many ways than I am in the psychiatry unit. We work together all the time. And treating these patients is very difficult. I think we've tried to kind of get across the complexity of these patients. Many's the time that I see a patient and I don't know what's going on, and I'll give Bob a call and say, hey, look, I got this guy, something's going on here, and I feel comfortable with it. Would you put him back in the unit and evaluate him again, because I'm just not sure about this. You have to be able to do that. And the mind-body split, mind like in psychiatry, neurology, that doesn't exist anymore. There is no split. This is an organic problem. Descartes did us a huge disfavor when he talked about mind and body. There's all one, it's an organism, and this is a physical problem. So when we work together like this, the probability of patients getting better and getting good care is accentuated.
But I want to emphasize one thing. The presentation of the diagnosis is pivotal in the patient pursuing treatment. If you don't present the diagnosis properly, you're going to make the patient run away from your unit.
Anyone who has this problem, knows someone who has this problem and wants to get help, should go to a comprehensive epilepsy center. It does take a multidisciplinary approach. It takes a place that can do video EEG monitoring. If you don't know how to find one, look on epilepsy.com or the Epilepsy Foundation website. Those are now conjoined in the same organization for Find an Epilepsy Center. It's not something that would typically be best handled in your primary care office unless that person has an unusual skill and experience set. Well, I think we ought to close the questions down now from our moderator, Ariella Karasoff, and we ought to open it to the audience. Would you moderate the audience questions as well?
Does anyone have any questions?
Yeah, I'd be interested if any of the speakers might talk to any significant cross-cultural or sociological issues related to this disorder.
So I live in Miami, which is the city next to the United States.
That's not cross-cultural anymore.
No, but it has a very rich cultural diversity. We have people from the Caribbean, South America. A lot of Europeans and Asians have also moved to Miami. And I have to tell you that you see these kind of situations very frequently. In South America, you see it with an increased frequency because there are certain cultures in South America where incest is actually an accepted, in quotes, an accepted practice. And so you will see it. I was born and raised in Mexico, and in Mexico we used to see that very often when I was doing my internship in the General Hospital of Mexico in Mexico City. And this was an expression of a lot of form of incest. And it's not only something that you see in Mexico, you see it in many countries in South America and where this kind of practice is done.
In Arizona, where I practiced for a number of years, we had the Native American culture, and the Navajos have described the hand-trembling attacks, which are highly correlated with epileptic seizures, and the moth and flame attacks, which is like a moth fluttering around a flame, which they correlate with the non-epileptic seizures. So they use different words, but different cultures see the same phenomenon.
Other questions?
So what percentage of the population has this disorder?
5% of the world will have a seizure in their life, maybe more, especially if you count the febrile seizures in children. Nobody knows really what the subset is who have non-epileptic seizures. It is a small percentage of people who have epilepsy. What number would you come up with, gentlemen?
With non-epileptic seizures?
Non-epileptic seizures versus epileptic seizures in a population. The study's never been done.
I think there was an estimate of 0.4%.
So that would be 4 out of 1,000 people with epilepsy would have non-epileptic seizures. But if you go to epilepsy centers where there's enrichment by referral, as Dr. Kanner said, some places will have a third to a half of the people referred for epilepsy turning out to have non-epileptic seizures because the seizures haven't come under control with traditional medicines. One of the things we haven't said that should be mentioned briefly is that some of the medicines work both for epileptic and non-epileptic seizures. So a medicine like lamotrigine, which is a seizure medicine, is also a mood-stabilizing medicine and would help both. If you're having complicated migraines with confusion bouts and you get put on topiramate, an anti-epileptic medication, it's also an anti-headache, a headache preventative medication. So sometimes we can be clever and cover both bets.
Other questions?
In terms of PNES, would you consider, would you be likely to see a wide variation in presentation of the episodes, say serial episodes?
Sometimes yes and sometimes no. If we see a wide variation, for me it makes the diagnosis easier because seizures are relatively stereotyped one to another. So if the presentation depends very much on the situation and is varied, I'm inclined to think, maybe this is not an epileptic seizure. But sometimes the PNES can be very stereotyped as well, or they may have two different types of PNES, each of which is stereotyped in its own way.
Okay, one more question.
Yes, I have a question. I get the impression that GPs can't recognize this from what you've all spoken about this evening. I lived through this. I had uncontrolled seizures for 22 years. And I got lucky one day. I was donating blood at Welch Road, and I had a very minor seizure while the IV was going in. The doctor on the prim came and, okay, you're going to the hospital and having a CAT scan. I ended up being referred to a great neurologist, PANTH, and then I was medicated and it wasn't working after a while. And you, Dr. Fisher, took care of me when I was in the hospital having video EEG, and I had neurosurgery 7 years ago. Never had another seizure, but for years, 22 years, I'm having complex partial seizures. They're getting worse and worse. But what's frightening is I'm driving around Woodside and Atherton with other people's children, plus my own. And it was really terrifying. I mean, my children still, if I just make a sound on the phone, I had my first seizure when my 3rd-year-old was 4 months old. We were talking the night, she heard me kind of make, Mom. It's just like a trauma coming back, because they remember me always pulling over the car, because at those days I had an aura, so I could pull the car over and wait for it to be over. But it's really common that these people don't know what, and they just say, okay, you're having a panic attack. But it's deadly, and I was told by a neuroscientist at Cal that I probably had lots of brain damage just from 22 years of having these seizures regularly until they became life-threatening, and I ended up under the care.
Good to see you again.
Yeah.
I really want to thank Dr. Fisher, Dr. Kanner, and Dr. Berry for joining all of us, and to thank the audience for being here tonight.